So now to our final speaker of the day, Dr. Byron Calhoun, who I introduced earlier on the subject of perinatal hospice care. Dr. Calhoun is a specialist in the management of high-risk obstetrics and the medical complications of pregnancy, and has managed thousands of high-risk pregnancies. He is Professor and Vice Chair of the Department of Obstetrics and Gynaecology in West Virginia University, Charleston. His practice and clinical research is concentrated on pregnancies complicated by maternal and/or fetal disease, and he is a specialist in maternal-fetal medicine. Dr. Calhoun has authored 68 peer-review articles in the obstetric and gynecologic literature and has presented more than 100 scientific papers, has participated in more than 40 research projects, and is a peer reviewer for various medical journals, including the American Journal of Obstetrics and Gynaecology. Dr. Calhoun will now address a symposium on the role of the maternal-fetal specialist in managing the challenges of high-risk obstetrics. Please join me in giving a very warm welcome to Dr. Calhoun.
Thank you. Well, I appreciate everybody staying. Once again, thank you for inviting me. I think it's really you're staying for the free cheese and wine, but I'll take what I've got, right? This is going to be an interesting presentation. I'm going to take you through some very exciting things, I think, in maternal-fetal medicine and in obstetrics and gynecology. I'm going to talk about a few controversial topics as well. Perhaps I'll stir it up, as Dr. Monahan said a little bit earlier. But what I'd really like to do is sort of give you an idea of what's really out there now in terms of really therapies for in utero therapy and some of the things that are really available for women and how we can treat women and babies better. And what we ought to be thinking about in terms of our advanced care. And as my dear father said, now that he's departed, is that, you know, if you have a hammer, everything's a nail. So let's open our toolboxes and let's think outside of our toolbox and find some other tools we might be able to have to improve care. My disclaimer, I'm not being supplied or anything bad I say is my fault, not the symposium or anyone else's fault. Well, let's talk a little historically. I would like to talk a little about the development of the fetus as a patient and a little bit about maternal-fetal medicine, near and dear to my heart. Talk about therapeutic options in our patients now that were wildly unavailable when I first started doing this, and talk about some therapeutic options in mothers, some particularly difficult cases that have been reported, particularly in the Irish database, and also in my own experience as a maternal-fetal medicine, and then some brief conclusions. Well, if you look at treatable, it depends, doesn't it? Remember that famous line from Alice in Wonderland, which I loved earlier, or actually Alice Through the Rabbit Hole or Alice Through the Looking Glass? Well, she's talking to the Cheshire Cat, and she says, well, which way should I go? And the Cheshire Cat says, well, where do you want to go? And she says, well, I don't know. Well, then anywhere will do, won't it? So if we don't have a way to treat, or we don't think about a way to treat, then we can't treat it, can we? And fortunately, Dr. Liley said, well, why are these babies dying from Rh disease? What's the pathology? Being the brilliant guy that he was, he said, well, they're hydropic, they're in failure. Maybe they're anemic. Well, they are anemic. Well, what if I try to transfuse them? Well, unfortunately, poor Dr. Liley did not have ultrasound, did he? But he had fluoroscopy, and that's what he did. And he went ahead and transfused babies and saved hundreds of lives, and then helped develop immune globulin to save tens of thousands of babies' lives in invasive procedures. I'm going to talk about bladder outlet obstruction. I'm going to talk about congenital cystic adenomatoid malformations. I'm going to talk about twin transfusions. I'm going to talk about neural tube defects in utero surgery. I'm going to talk a little bit about sacral toccygeal teratomas. I'm going to talk some very exciting things about hypoplastic left and right hearts, which you may or may not be available, or know that are available. I'm going to talk about SCIDs, or combined immune deficiency. I'm going to talk a little bit about fetal arrhythmias, which is kind of an interesting topic for me since I see that from time to time. Well, as we looked at embryology and we figured out how this all came about, and we were able to, with ultrasound, to start looking into the black box of the uterus, and we discovered that all these different things were going on by Dr. Lejeune for prenatal diagnosis and Down syndrome, and we started getting us this very, very wonderful way in which we could look inside the uterus, the black box, if you will, of pregnancy. We started finding things we really didn't know what to do with, and we were a little bit unprepared for that. We also were not really prepared for the impact it would have on us as physicians, because now we suddenly realized truly there were two patients. And every obstetrician knows there's two patients. That's just a given for when you're doing obstetrics. And even our colleges recognize we have two patients involved in our care. And so when we do these therapies, we're balancing, again, What's the best care for mother and baby, taking into account both of them and both of their lives and both of their benefit? So we're going to talk a little bit about the science of in utero therapy, and I think this is where it's very exciting, and you can sort of think about how this might go in the future. We talked a little bit about Dr. Liley. We also talked a little bit about prenatal diagnosis of anomalies and in utero conditions. So let's talk about some of these things. Again, that's the list. We're going to try to go through some of these things. I'm going to talk briefly about these areas that are now open to either in utero therapy or therapy across the placenta, things that were not available to us 10 or 15 years ago. These are all diagnosable in pregnancy, now all theoretically treatable at some stage or some way, shape, or form. Well, if you look at bladder outlet obstruction, basically it's an incomplete cannulization, right? The urethra doesn't form properly and the distal urogenital sinus. It's actually not that common, but it's about 1 in 5,000 or 1 in 8,000 fetuses. And what you basically see these babies dying from is pulmonary hypoplasia. You have to have amniotic fluid, obviously, to develop your tertiary bronchioles and your alveoli, correct? So they have a block. And if you have a block and you have kidneys that are still functioning and can prove that, you can actually fix it, right? And how would you fix it? Well, glad you asked. You have a keyhole bladder. What do? You put a catheter in it. Well, that's really interesting. Does anybody know which catheter this is? This is the rocket catheter developed by the docs here in Ireland and the UK. And it's actually a pigtail catheter, which you put in the bladder. So there's a pigtail in the bladder and a pigtail out, shunts it. The fluid reaccumulates, the kidneys recover if they're functional, and these babies are actually born and actually do quite well. Some of them may have chronic renal failure, some of them actually develop totally normally. Very interesting stuff. Again, something you would never have been able to do 20 years ago. You couldn't put catheters in, you couldn't see how to do that. So what was once not treatable, pulmonary hypoplasia, a bladder outlet, now is treatable. Isoimmune high drops, again going from 43.3 per thousand people or children to 2.6 per thousand after a ROGAM was developed and given at 28 weeks in my country and also postpartum and after spotting or bleeding for all our Rh negative patients. Again, just some demographics. Again, scalp edema with severe hemolytic anemia. When you see that, that's a very bad thing. So what do? Well, we used to do all these amniocentesis. Anybody here old enough to remember doing those? Anybody ever do those serial amnios? Dr. Chiro saying, yeah. They were very, very bad. Weekly amnios and putting at risk for rupture membranes, infection, ugly, ugly, ugly. And also when you did your transfusion, you put it in the abdomen, which if they were hydropic, they all died because, of course, you don't absorb well. Yeah, not very satisfying. Now what we do is we do Dopplers. And what do we know about Doppler? Well, if you remember your physics, Doppler flow is related to resistance. It's also related to how much blood you have flowing past a certain point. When you become anemic, your rate goes up. So you look at blood flow and you can determine just indirectly without doing all these amnios if the patient has anemia or is at risk or not. And then we now do cordocentesis. And what we do is we do these as early as 18 weeks. We can put a needle in the cord, get a transfusion, and or check hematocrit. Again, these are things you couldn't do before ultrasound 15, 20 years ago. We're sort of like out there somewhere in the space zone, right? And most of these babies do very, very well. Most deliver at 35 to 37 weeks, which, as we heard earlier from our colleague from Belgium, that's when you want to deliver after 34 because that's when prematurity has less of a bad effect than before 34 weeks. Congenital diaphragmatic hernia, a very, very bad actor, especially if it's rather large. Relatively unrare, or relatively uncommon, but if you do enough of the prenatal care, you're going to encounter this. Originally not very well treated because if you tried to treat them originally in utero and repair them with surgeries, you would actually cause problems and the babies would die. So what we've done now, actually, is after they've diagnosed it with a rather large diaphragmatic hernia, see if I have what they do now is there's a trial in San Francisco and other places, actually I think there's one in Europe as well, using a video technique where you actually go in with basically a video camera, much as you're doing a laparoscopic procedure with a relatively flexible scope, and put a plug in the trachea. And it goes, why would you put a plug in the trachea? Well, if you know about fetal physiology like we all do, what comes out of the lungs? Fluid, right? So if you block the fluid, you increase the pressure, the lungs grow, and guess what they do? Just like inflating a tire, they gradually inflate and push that diaphragmatic hernia down slowly, and those lungs reinflate and grow, and the diaphragmatic hernia is healed. And then they take the baby out. Well, it's got a plug. How's it going to breathe? Good question. You deliver the baby to the chest. trach the baby. It's an exit procedure, and then you pull the plug later, and they actually repair the diaphragmatic hernia after that. They've been doing this now for several years, and they have had a 75% success rate with doing this. Again, something that was really not curable, really 10 or 15 years ago. Diaphragmatic hernia is very, very bad. What about what's called a congenital cystic adenomatoid malformation? It's a rather large pulmonary mass. Has anybody seen one in here on ultrasound in their practice? No? It's not all that common. It's not all that uncommon. Generally what will happen is you'll see it early and then it disappears. Thank the Lord, because they can be really ugly. Unilateral is very common, bilateral in less than 1 or 2% of the cases, and they have 3 different types. There's the rather large macrocystic type, then there's the kind of the mixed, and then there's the very small, very echodense areas. And generally these are areas that are improperly formed, and so you get a large cystic formation or very dense areas in the lung. The problem is if the cysts grow very large, what they do is they compromise the trachea and the vena cava, and they go into failure. So that's really what happens. So what can we do? Well, you can do an open resection, or what do we do with our baby who had the big fluid-filled bladder? You put a pigtail in, you drain the cyst, relieve the pressure, everything realigns, the hydrop resolves, and the baby does just fine. What's very interesting about this is if you do enough of these procedures, my favorite story about this is we actually paralyze the babies. You use pancuronium or something like that, you inject them, and you give mom sedation, obviously, and you do anesthesia and all that. Well, we got this all done, and we went in 24 hours later, and my little friend had decided he really didn't like that chest tube, and he had pulled it out, and he had it in his hand and was waving it like a big club at me, telling me he really didn't like that in his chest. So very interesting. So babies can just do all sorts. So I had to put another one, of course, because he still needed it, but it was very interesting. He thought he was so sick he couldn't do anything. He knew right where that was, pulled that rascal right out, just like a chest tube. And this is what they look like on ultrasound. Again, heart is shifted massively to the right, solid cystic components, and this is very bad. Obviously, you see a lot of vascular compromise, and these babies die if you don't shunt these. What about neural tube defects? I know you're very familiar with that here in the UK and British Isles, Ireland. Well, everybody in Appalachia, where I'm from, is actually Scots, Irish, English, Welsh, Northern European extract, most of them. And so in a very concentrated low movement area, as we like, of course, Dr. Charot says that the gene pool is somewhat shallow, which I take great umbrage at, but all right. But it's a lot of Northern Europeans. So we see a lot of neural tube defects in the past, or we did. But now, with folate, which was brought up earlier, we see very many fewer. Instead of 1 in 3, 4, 500, maybe 1 in 1,500 to 2,000 now. So about a 50 to 75% decrease in some areas, more like 15 to 40% probably in most studies. Again, this is a neural tube defect. I don't know how well you can see this. This is one actually in my own practice. You can see that the splaying down here, this is a large needle in this patient, and it's right around 24 weeks. We usually diagnose this obviously by alpha-fetoprotein usually, or the classic, why is it everything's food? Lemon sign, banana sign, all this kind of stuff, but that's what it is. Lemon sign pulling the cerebral hemispheres posteriorly, and you can see the frontal lobes begin to be pulled in. Posteriorly, you see disappearance of the posterior fossa, and that's called, as the cerebellum fills with the banana sign. And that is classically always associated with an open neural tube defect. Well, anencephaly is lethal. We can't fix that yet. But spina bifida is variable, and there's some very exciting things. And if you've read any of the literature on the latest study that was done in the United States, and I think they're actually talking about some of this in Europe as well, of the management of meningomyelocele. And what they did is they actually went ahead and randomized patients to 2 groups. And they said, what if we get 100 or 200 in each group? But they stopped at about 183 of the 200, 100 in each group, because they found by mid-analysis that there was enough data to support that this was really quite effective. And what they found is they did 2 primary outcomes. They said, is there increased risk for shunting, and what's your mental and motor function? And shunting is critically important because that's where the damage and the infections come in, and you get decreased mentation, you get more problems when you're putting shunts in the ventricles and doing the vesicoperitoneal shunting. They also wanted to look at motor skills. And what they found the risk for shunting with prenatal surgery is only 40%. Compared to 82%. And this reached very high statistical and clinical significance in these particular patients. What they also said, there was also an improved composite score for mental and motor development. And as Dr. Levin pointed out in Belgium, these were Bailey's managements. They had motor skills, and these were up to 2 and 3 years of age after this, not just initially, but actually 2 and 3 years out, 4 years out, and found that these children actually were doing much, much better. And the other was a secondary analysis for ambulation, which they found was much increased at 30 months. The final thing that was in there that's kind of buried in the analysis, which parents really want to know, is continence. Both urinary and fecal continence was improved in the children who had undergone surgery. So they maintained some continence of the urogenital diaphragm, and that's key to parents. I mean, nothing's worse than having to deal with that as a parent, frankly. Ambulation without orthotics was improved, double in the kids who had gone intrauterine therapy, those who didn't. And then surgery patients, of course, had an increased risk for preterm delivery because you had to open the abdomen up, pull the baby out, repair the meningomyelocele, put the baby back in, sew the baby back, put them back in there. And I didn't show you all that. I didn't have time for that at this point. Teratomas. Now, these are pretty rare. I mention this only because if you ever see one, you never forget it. It's the most frightening thing you'll ever see in a baby. You put the ultrasound on, and there's something that's off the backside of the baby that looks like a meningomyelocele, but it's larger than the baby. And that's actually just basically a sacrococcygeal teratoma. Mortality rates are very high with high output. Here we have a nicely done, this is a huge sacrococcygeal teratoma, and you can see the vascularity on the Doppler, and this is a velocity. This is hugely elevated. Normal blood flow should be here in the 25 and 30 range. You're talking 97 meters per second. Huge amounts of shunting and blood flow. And these babies die just like the babies do from RH disease, from high output failure. So what do? Well, there's what you do. You take this little person out at 23 or 4 weeks. You take that large mass off. You close it up, and those kids do absolutely fine. As long as it's not malignant, it's fine. And you know what's really interesting about fetal surgery? Babies just don't really scar. For whatever reason, they just don't really scar. So there's very minimal scarring with this babies when they do the neural tubes and or this sacrococcygeal teratoma. But very impressive. That's about a 24-weeker that they did that on. What about the skids? Everybody talks about severe. These are the bubble kids. Remember the bubble babies, the bubble kids, the kids in the bubbles who are basically B-cell, T-cell, totally immuno-incompetent. They always die by some sort of infection. Well, what's really interesting now is what we can do is, because you become immune competent by 14 weeks, but they don't, you can put stem cells in through the cord, and what happens? You engraft. And usually use maternal stem cells. You engraft, so now you're a chimera, so to speak, and now you have all your T cell, B cells, and all your other lymphatic and your hematopoietic components, and you're just fine. You're now immune competent. Well, everybody says, well, why can't we treat sickle cell disease by just doing this? Or why can't we treat anemia, beta thalassemia? Why can't we treat that? Because you get into the graft versus host. By the time you hit 13, 14 weeks, you can't do it. And we just, at this point, we have not been able to beat that immunocompetence in these babies yet. That may be in the future before too long, but right now, we just can't do that at this point. But if you could treat it. Interesting side note, I had a young lady who came to me who had a primary biliary cirrhosis as a child. She was born with this, neonatal, very rare. And she was treated with a liver transplant in Pittsburgh. This was 20 years ago, or 24 years ago, sorry. And she came to me and I looked at her chart and I said, but where's all your drugs? She goes, well, I don't take any drugs. I said, how can you have a liver transplant and not take any drugs? And then of course she gives me the lesson, I'm the stupid obstetrician. She goes, I'm a chimera. I had implantation of hepatic and hematopoietic stem cells when they did the transplant because they didn't rinse the liver out well enough because it was an emergency, and they implanted it, and I'm fine. I don't take any anti-rejection medications. She was absolutely stone cold normal. She took no anti-rejection drugs. Her liver function was stone cold normal. She flew through pregnancy, had no problems whatsoever. It was unbelievable. But that wasn't something we did. That was something that somebody else did at a higher level than us, frankly. What about twin-twin? You've got to have seen this. Somebody's got to have seen twin-twin. Nobody? Nobody's seen twin-twin? Yeah, okay, good. This is really quite common in my practice, and it's actually one of those things that's getting more and more common because as we do more and more in vitro fertilization where I come from, and we see more and more multiples, we get more and more problems with this particular issue. If you look at its growth discordance, marked amniotic fluid volume difference, and hugely divergent hematocrits. These are usually almost always monochorionic. In fact, they virtually are all monochorionic twins, not dichorionic. What we think the problem is, if I can get it to go, is there's anastomosis. So if you think about, again, physics, I know it makes my head hurt too. If you think about high flow, low flow systems, you get a donor twin that has a high flow arterial shunt to a arterial venous side on the receiving twin, and the baby that pumps high pressure to the low pressure baby shunts to that baby, decreased flow to that one, smaller baby, low fluid, not such a good thing, right? The small donor has severe oligohydramnios, very, very severe growth restriction, and the recipient twin has extra fluid because, of course, as you become more overloaded with your blood volume, you try to urinate more, and they get hugely discordant amounts of fluid. We used to do serial amnio reductions where you draw the fluid off or you create a window between the babies. Does that make any sense to anybody? Why would you do that? Well, yeah, you'd be desperate. But I've always thought, then the cords can tangle or something bad. Anyway, you're desperate. You can do aggressive protein therapy. Believe it or not, if it's not severe, you know what the treatment of choice really is for my friends who do all this every day and do all this in utero laser? High protein shakes 3 times a day. High protein shakes 3 times a day. And what really is interesting about that, it actually works. It actually works because there's a protein problem with mom, and if mom solves it, the amino acids go across the placenta, the baby's able to resolve that, make the amino acids into the proteins they need, and actually may resolve that particular problem in the probably stage 2 or 3, not the severe ones who are already severely affected. There's a couple really good people. Dr. DeLee is actually in Milwaukee and a dear friend of mine, and reported on 153 cases of laser, where you open up and you go in with your laser, and you blast the anastomoses. You look at them under laser, and you basically coagulate them, so you stop the arteriovenous shunting. And what he looked at was he did these at 21 weeks on the mean, on average for the twins, right? He had 82%, at least one baby survived. 94 of 134 of the twins actually did survive. 32 were surviving twins. 18 had at least one surviving baby. 12 did not have any. 4.3% had significant handicaps. Now, what's really interesting about that, of course, that's related to when they delivered, right? If you go into his paper, it's when they delivered. The average problems with twins is probably about 4% because the majority of twins deliver between 35 and 37 weeks, 38 weeks. So if you deliver below 34 weeks, you get problems, right? Maybe related to this, maybe not. So what he found out is he followed up with a mean follow-up of 60 months that if you do in utero surgery and laser and fix this, these kids do great. Much better than with amnio reduction in the severe cases. Again, this is like space-age science stuff. And I thought about putting some videos in, but a limited time thing. It's unbelievable watching him go in with a laparoscopic instrument and start blasting vessels and coagulating. And 24 hours later, you see these kids fluid normal, high drops resolved. It's like magic. It's like space medicine, right? Well, tachyarrhythmias are one of those areas that are a little unusual, but I see them not infrequently. I don't treat them once the babies are 34 to 36 weeks because it's better off probably out than in. These are, I think, very difficult to treat. It's hard to get the medications. Remember our dear friend from the cancer world said, you can't get drugs across the placenta. It's true. You can't get drugs across the placenta. It's pretty hard. And I've used Digoxin until mom was practically digtoxic, and the baby's like not even buying any of that. I've tried flecainide, not very effective actually. I've tried all these different things, even quinidine. I thought, well, no, I didn't. I don't recommend the gin and tonic, but I give them quinidine, yeah. And propranolol. What I also have done, which is extremely scary, has anybody done adenosine in an ER for anybody in a supraventricular arrhythmia? An adult? Anybody ever? Dr. Shiro said, the most terrifying 6 to 10 seconds of your entire life because their heart stops. The baby's heart literally stops with the adenosine. You inject it in the cord, you watch it, the heart is in a superarrhythmia, it goes from like 230 to 0, and it just sits there. And it sits there. And it sits there. It's like the world's longest shoulder dystocia, you know what I'm talking about? Yeah. And then it's like magic. It just starts right back up. And if you break it and you have them on therapeutic medications, it works great. Again, could never have done this 25 or 30 years ago because I couldn't get in the cord. I had no way to get the needle in there to do this directly into the cord. Amazing stuff. Bradyarrhythmias, more common structural defects. I can't really put a pacer in yet, although I've talked to some guys who are in Boston Children's and they've talked a little bit about that. Hypoplastic left. Anybody seen that? Somebody's got to have seen or know somebody hypoplastic left. Bad actor, right? Ugly, really, really bad. Not good at all. Can be an autosomal recessive. Recurrence risk can be very high. What do you do? Well, left ventricle's not good. Usually have some sort of either a pulmonary issue and or a aortic issue, or you can have both, or you can have a mitral stenosis or mitral atresia. Any of the variations, but usually mitral, right? What do we do with people who have mitral stenosis now that we can't put a valve in? Valvoplasty, right? You go in there and you take a balloon and you pop it open and give them flow. Well, what's interesting is Boston Children is doing just that. I had a patient 4 years ago now, had a hypoplastic right ventricle. I found this at about 23 weeks. Called my colleagues up. I'd found out that they were actually doing this, had a protocol, sent her to Boston Children's. They catheterized the baby in utero. I know, I'm going like, you did what? Yeah, we put a catheter in. We went into because it was right side. I went to the pulmonary, popped it open with the catheter, got increased flow, and it's looking a lot better. We did that twice. She actually had enough growth of the right side of the ventricle. For the child's had, I think, one diverting surgery, and maybe we'll be doing a second. But it's developmentally normal. He grew normal. His heart's grown actually quite normal. They think he probably will have a biventricular heart instead of a univentricular heart, which is critically important to this. And they're doing this with hypoplastic left if they can get into the mitral valve and open it up. That's the key. If it's atresia, there's no way to get in there, right? Well, again, small ventricle therapies are quite complicated, 3 stages, Fontanne. Now we're talking about early with catheters. We're still in the early stages of this, but, again, if you don't think about it, it can't happen. If it's not in your world of what could be a possible diagnosis, you can't diagnose it, can you? If you don't have it in the differential, you can't do it. Like maternal mortality, if you don't think preeclampsia or you don't think sepsis, you don't think it, you don't treat it, right? Well, what about maternal complications in therapy? What, I got about 15 minutes? Is that about right? 15, plus or minus? Okay. We're going to talk a little bit about this then. Well, cardiac disease is really my biggest area of, not preeclampsia, that's bad enough for me. Cardiac disease is my biggest problem for me, where I'm at. And it accounts for the most deaths I've had in my career with Marfan's, someone with a significant critical mitral, and aortic dissection from a lady who had Ehlers-Danlos as well with preeclampsia. Congenital heart disease is actually the most common thing you see. Again, there's all the varieties you'll see in everybody who has now had any sort of cardiac disease. And our cardiac surgeons, bless their hearts, have really helped us out, haven't they? They're fixing them all. And now they're all getting old enough to reproduce. They're all getting pregnant. They're all coming to me and to you. Oh, by the way, I have a corrected tetralogy of Fallot as they walk into your office. Just, oh, by the way. Yeah, have you ever had that happen? Get to the very end of it. Oh, by the way, what's that scar on your chest? Oh, that's my tetralogy of Fallot. Well, if you look at moderate disease, aortic stenosis, coarc, uncorrected, sort of in the middle, right? You can treat it, but it's got to be somebody who knows what they're doing. Interdisciplinary, right? Major is pulmonary hypertension, which I'm going to talk a little bit more about. Marfan's and Ehlers-Danlos syndrome, and coarctation of the aorta, which is complicated as well. Well, if you look at pulmonary hypertension, it's pretty rare. 1 to 2 cases per million per year. You might see one of these every few years here in Ireland. Mortality was previously thought to be about 30 to 50%, 5-year survival 27%. Latest studies are much better. 5-year survival is now 54%. Survival-related therapy are not improved with abortion or termination. Okay, so it doesn't help you. Because the problem is the heart is not affected by that. That's not the problem. The problem is pulmonary hypertension, right? If you look at cardiac disease, what you need is excellent preconceptual evaluation. You need consultation with an MFM. You need delivery to a high-risk center. You need strict fluid take. You need telemetry, invasive monitoring, and all that stuff. You don't need to terminate pregnancies. In fact, I'll tell you categorically, I never recommend termination of pregnancies for cardiac disease. It doesn't help. And in fact, more likely to cause problems because you have to do the anesthesia and all the other things anyway, and that's where you kill people. That's where people die. Marfan's syndrome, autosomal dominant or aortic root. I use beta blockers. I have 2 patients with Marfan's I've taken care of this year, and one with Ehlers-Danlos, which I'll talk about in a minute. Termination of pregnancy does not change your prognosis no matter what's going on in Marfan's. If your aortic root's dilated, doesn't matter. Your aortic root's not dilated, it doesn't matter. Pregnancy is not the issue. Treatment with beta blockers is the issue. Ehlers-Danlos is a very interesting disease. I have 2 patients I've taken care of this year, believe it or not, and they're not related, Dr. Chareau. She was going to say, oh, they're probably cousins. No, they're not. Prevalence is about 1 in 5,000. The problem with Ehlers-Danlos is it's a very, very ugly, sneaky disease. You can have a totally normal aortic root, it could be 3.7, and they'll blow the aorta out and die. The other interesting thing that they have that people don't understand and realize, and if you don't think about it, they have a really high incidence of basically hyperthermia in general anesthesia. So if you don't talk to your anesthesia colleagues, they are not going to be happy with you if they put them to sleep and they suddenly have malignant hyperthermia. Bad idea. Again, treat them with beta blockers and have them come see me or one of the other people you don't really like because they get to take care of them for you. Yeah. Well, let's talk a little bit about hematologic disorders. And I want to talk about this only because there was a maternal death that was quoted, or not maternal death, an abortion that was done in Ireland for hemolytic anemia, autoimmune hemolytic anemia. I'm trying to keep with the English spellings, you notice I'm trying to be politically correct here. Because this is not my way, right? This is like your way. It's really H-E-M-A, right? That's the correct English spelling. Oh, no, that's the American way. Well, what about autoimmune? Most of the time we don't know why it happens. It may occur with the result of pregnancies. There have been several case reports of women who got pregnant, have autoimmune hemolytic anemia. It resolves after delivery for whatever reason. Steroids get an 80% response, splenectomy the other 60%. If you're refractory to therapy, because of course now we know you can give people plasmapheresis or immunosuppressive therapy or even chemotherapy if you needed to do this. Theoretically, immunosuppressive therapy is the way to go. You don't need to do anything else. You treat people. You don't abort them. You don't have to. It doesn't work. It doesn't change it. Mental illness. I'm not going to go over this very much except to tell you that I know of no study that shows an improvement in mental health with abortion, okay? It just doesn't happen. I know you've heard it, oh, they feel relief, there's all these other things. But if you look at the mental illness things with anxiety, if you look at depression, if you look at maternal mortality, if you look at death, if you look at improvement in maternal health, it's just not true. And you got to read the data. You've got to read it carefully and closely. Don't believe urban legends, believe what the data really says. And read it carefully. I'm not going to do that. I'm going to talk about rupture of membranes. Now this is where we can really make the rubber meet the road and you can do the most good. There is hope here, right? I like hope. I like hope. I like giving people a reason to do something constructive for themselves and their baby. Everybody says if you rupture membranes before 20 weeks, oh, it's a disaster. It's a disaster. Oh, horrible things are going to happen. You're going to die, blah, blah, blah. Not true. And I'm going to show you what the data really says. Occurrence is about 0.7% depending on where you do. Up to 15% may reseal. Anybody have had that happen before in their career? No? Yeah, I've had it happen multiple times actually. It's just amazing. No fluid. See them next week. Membranes are sealed. They have normal fluid. They don't leak again. I don't know what that is. I don't know whether stop leak or what it is, but it just happens. 57% will deliver in the first week, 78% will deliver after 4 weeks. So there was a huge analysis that was done putting together about 1,055 patients, which is a lot of patients that a friend of mine and I put together. This is from about 2006 or 7, I think. Stillbirth rate, 14%. Neonatal death rates, about 40%. Survivors, about 46%. Let's talk about that. Well, they're all horribly damaged, they're all whatever, right? Well, actually, no. If you look at survivors 3 months to 6 years of age, and you followed up the ones who actually survived, which is 84%, 70% of these babies were neurologically intact. And in fact, the babies who were the most high risk, the ones that ruptured below 20 weeks, and they had outcomes for, the majority of them were neurologically intact. Wow, that's not like I've heard before, is it? Yeah. So why is that? It's because it doesn't depend on when you rupture your membranes, it depends on when you deliver, right? So if you rupture at 23 weeks and you deliver at 27 weeks, that's different than if you rupture at 18 weeks and you deliver at 22 or 23 weeks, right? Or if you rupture at 20 weeks and deliver at 24 weeks. It actually has no bearing whatsoever on when you rupture, but when you deliver. Also, maternal mortality is not increased. Maternal morbidity is not increased, and I don't have those slides in there, but if you want them, I can send you the full lecture. I've got the whole thing. I just didn't have time for all that. So it's not true. So hope can be fostered by women saying, go home if you'd like. We're going to watch your temperature. We're going to watch you closely. May keep you for 12 to 24 hours in the hospital, observe you. We're going to see you frequently, and we're going to watch the baby and see what happens. Realizing you're going to have a certain number will die, and almost all are going to deliver prematurely. At 24 weeks, I put them in the hospital. That's my own thing. I give them steroids, and I monitor them very aggressively if they want me to, if I put them in the hospital. And we deliver for fetal indications or for labor, right? So pre-viable rupture membranes, things are not as bad as you would think they are. In fact, you can be quite sanguine in saying, there's a certain number of these babies are going to survive, and a lot of them are going to do very well. They're not all going to die. They do as well as other age-matched controls. You got to watch mothers for infection. You got to be very careful. This is not cavalier management. This is not ignoring. This is very aggressive, conservative management, as I call it. Well, in conclusion, I really want to leave with the idea that there is so much wonderful stuff out there. Remember, if you have a hammer, everything's a nail. It's not true. There's multiple tools out there. There's all sorts of things we can treat. All sorts of stuff we didn't think we could treat, we now can. So think about what we can do and understand what was not treatable is now treatable. We also have this huge, wonderful area of in utero therapy. And it's very exciting to me that we now know that termination really does not improve outcomes, and we can think now about creative ways to treat babies that we could never do before. We have all these tools to do that. And like I said, when all else fails, just provide excellent care like you do in Ireland. You have low mortality, you have low morbidity, and you have the best health care in the world. What more could you ask for your women? Thank you.